most of us are familiar with cholesterol and its relationship to diet. This was a study published in 2017 on the consumption of a high-fat diet, which was 39% carbohydrates, 25% protein, and 36% fat with 18% saturated fat, was associated with an increased total cholesterol and LDL cholesterol. However, several studies concluded that dietary cholesterol does not increase the risk for cardiovascular disease. Dietary cholesterol or exogenous cholesterol accounts for approximately 30% of the body cholesterol, while the remaining 70% synthesized in the body or endogenous cholesterol. As part of the homeostasis process, endogenous synthesis of cholesterol by the liver is reported to decrease with an increased intake of dietary cholesterol. So they do still play a role and interact with each other. And here's some information, some of the citations on the cholesterol and the metabolism and that. A little bit more on cholesterol and diet. A meta-analysis and systemic review that evaluated published studies from 2010 to 2017 concluded that reducing saturated fat and replacing with carbohydrate will not lower coronary heart disease events or cardiovascular disease mortality. Replacing saturated fat with polyunsaturated fat, monounsaturated fat, or high-quality carbohydrate will lower coronary heart disease. So you can see, and most of us are aware, that is the source of sort of the fats, the cholesterol, versus just the total number itself. And then there's the citation for that. The second point here, some cholesterol containing foods like eggs were previously thought to be harmful. However, one egg contains only 1.56 grams of saturated fat and is nutrient dense, economical, and an affordable way to increase the intake of protein, vitamin A, phosphorus, potassium, B6, and B12, choline, which is an essential nutrient for human liver and muscle function. So tend to be very nutrient dense. And again, as previously mentioned, there are several other factors besides just what the patient is putting into their body that will play a role with this. But obviously, if we eat too much of anything, it usually can become a negative. So cholesterol and statin prescription. So this study was done on 12,740 Korean adults. You can see the age range, screening, this was between 1993 and 2008. And they looked to evaluate the association between cholesterol levels and cardiovascular related mortality. The authors reported that both low serum total cholesterol and highest serum total cholesterol were associated with higher risk of death due to cardiovascular diseases. So again, the point I made that, especially you do want to have a good level, whether it's the LDL, total cholesterol, you don't want that to be too low. Caution should be taken in prescribing statins for primary prevention among people at low cardiovascular risk in Korean adults. Another study conducted in Japan with 12,334 healthy adults age 40 to 69 also reported that low cholesterol was related to high mortality, even after excluding deaths due to liver disease from the analysis. And again, it's interesting if those substances, hormones, vitamin D are made from cholesterol. Well, if we're too low, that's going to throw off those. So it'd been interesting if they maybe would have measured some more of those downstream factors to see if that low risk or the low cholesterol levels led to lower levels of some of those other substances. Here's the citations for that information on the previous slides. Now, LDL, again, usually called the bad cholesterol, but as we saw with the total cholesterol studies, you still do need a healthy level of this. We don't want this to be too low either. They typically do, though, have a direct relationship with coronary artery disease. So you can see this one does range usually up to 99 or 100 as the max. Usually, again, elevated levels are the most common. Low levels indicate conditions such as liver disease, malnutrition. But again, you got to be pretty low on that range. Overuse of medication, obviously, may even be part of that as well. Elevated LDL are commonly associated with the same lifestyle factors as low LDL, and that's why we usually see an inverse relationship with them, but could also, again, be liver disease, medications, genetics. Then oxidized LDL particles have been shown to induce endothelial stiffness. There's a study, some information on that. We'll talk about the oxidized LDL in just a little bit as well. If we have to high LDL levels, obviously we want to lower those. So simvastatin or statins, very common. Berberine also can have a potential effect. So berberine, they've identified it as a novel cholesterol lowering drug acting through stabilization of the LDL receptor, messenger RNA. So they treatment in food-induced hyperlipidemic rats. So again, they took a rat study here. They found that berberine 90 milligrams per kilogram per day oral with the simvastatin reduced serum LDL cholesterol by 46.2%, which was more effective than the simvastatin alone, 28.3, or berberine alone, 26.8%, in their monotherapy. And similar to that of simvastatin, at even a little bit higher dose, they're double the dose at 12 milligrams a day. So you can even see, though, with the 6 milligrams per day of the simvastatin, the 90 milligrams per kilogram per day of the berberine basically had the same effect. I mean, that's only a 1.5% difference. So that's good. But when using them together, you can see they have an additive effect. The therapeutic efficacy of the combination was then evaluated in 63 hypercholesterolemic patients. So they took this previous information that showed that the combination had a better effect, and they did a little bit more. And they found that after 2 months, berberine 500 milligrams twice daily lowered LDL by an average of 23.8%, and a combination of simvastatin 20 milligrams daily and berberine lowered LDL by an average of 31.8%. Similar efficacies were observed in the reduction of total cholesterol as well as triglycerides in the patient. Total cholesterol seems to follow. Triglycerides, nice effect there with the berberine. So the authors reported that the study results display the rationale, effectiveness, and safety of the combination therapy for hyperlipidemia using a berberine extract and simvastatin. And it could actually be a new regimen for hypercholesterolemia. So it's nice when we can sort of do this integrative part of it. But I always sort of looked at this was, hey, let's add in, if a patient's already on, the simvastatin, let's add in the berberine, work on other factors, diet, exercise, a few other nutrients, other ones that we'll talk about here. And then once it gets to a certain point, maybe we can take off the medication and then continue working. And then maybe they don't even need the berberine anymore. And that should be the ultimate goal, not just to use these nutrients, these natural ones, herbs, as a substitute for medications, but can we use them as maybe a safer alternative till we correct the underlying cause? Now, what about all three of these? So cholesterol, we want to raise HDL, lower LDL, we want to affect triglycerides. And we've already seen that a little bit. As I mentioned here, it's beneficial to usually try to find whether it's an herbal treatment or anything that can impact the patient in more than one way. So this study looked at extract called amla of Emblica officinalis. And you can see reductase inhibitor, simvastatin, so, different things there. So they looked at the efficacy of amla in patients with type 2 hyperlipidemia and compared its hypolipidemic effects with those of simvastatin. You can see 60 type 2 hyperlipidemic cholesterol. None of the patients receiving either amla or simvastatin therapy reported any adverse effects, during the treatment or 2 weeks after. Out of the 60 selected, 40 were treated with amla. You can see 500 milligrams daily for 42 days, and 20 patients were given simvastatin capsule daily for 42 days. After the day of enrollment, all patients were followed up twice during the 42-day period. Total cholesterol, LDL, HDL, VLDL were measured before and after completion of the treatment. A treatment with amla for 42 days produced significant decreases in the mean levels of total cholesterol, triglycerides, and a significant increase in HDL levels. Similarly, treatment with simvastatin for 42 days produced a significant decrease in the mean levels of triglycerides, total cholesterol, VLDL, LDL, VLDL, and triglycerides, and a significant increase in HDL levels. Both treatments produced nearly equivocal alterations in lipid levels. And we know, even though they said in this study there were no side effects, we know the side effects that can come with statins. This amla, unless you're allergic to like an herbal product, natural product, really low propensity for side effects. And you can see with this, all the patients tolerated it well in this study. And basically you could use this as an alternative. So if you have a patient that's been using a statin, simvastatin, for instance, as they mentioned here, and had the negative effects on the muscle pain and that, it might be worth switching them over to an amla, type product or capsule. You can see 500 milligrams and see what effect it has. And hopefully then they have the reduction in pain and weakness from the discontinuation of the medicine. Some additional benefits of amla. So the same study found a reduction in blood pressure as well. So of the 40 patients receiving amla, 28 were hypertensive, while of the 20 patients receiving simvastatin, 10 were hypertensive. At the end of the treatment, a total of 27 patients showed improvement in their blood pressure. Of those, 21 were on amla and 6 on simvastatin therapy. So a little over 3 times the amount were on the natural versus the simvastatin therapy. So again, besides just affecting the cholesterol, lowering the total LDL, raising the HDL, lowering triglycerides, some of these natural products usually work in other ways. And this study also find a lowering of blood pressure because a lot of the times you might see those go together.